how do you view these four trials?
I think, well, the other trial that comes into play, and we're really talking primarily about non-squamous cell lung cancer now, but some of the trials have had both histologic subtypes, and the one I'm thinking about is the Checkmate 227, which was a complicated study, also published in the New England Journal, but which evaluated, included a immunotherapy combination, nivolumab and ipilimumab versus platinum chemotherapy, and then also a nivolumab chemotherapy arm. So in that trial, the addition is that it had a co-primary endpoint of tumor mutational burden. And as you know, and for our audience, this is an emerging biomarker for immunotherapy. The study was positive for the group of patients that had high TMB, which was defined in this study as greater than equal to 10 using the Foundation 1 assay. And the reason I bring it up now is that in that trial, if patients had high TMB but absent PD-L1 in their cancer, they still had an equivalent benefit for progression-free survival. And in fact, the patients that had low TMB and low PD-L1 had no benefit whatsoever. In other words, they did just as well with platinum chemotherapy. So when we talk about the other trials that have not incorporated TMB, you have to wonder, well, what if you had TMB and PD-L1? So at UC Davis, we use both. Now, some people would say that's premature, but we have a research and clinical collaboration with Foundation Medicine. We get the Foundation Medicine test. We have our PD-L1. And if we have it in a timely fashion, we use both of them to make a determination. So for me, regardless of the TMB and PD-L1, just based on the PD-L1, monotherapy with pembrolizumab would be my choice of therapy for patients with a PD-L1 greater than equal to 50%, based on the Keynote 024 and more recently the 042. I think that's very solid data. I'm sure that some of our colleagues or practicing oncologists who are in favor of the combination of chemotherapy plus pembrolizumab in this setting might favor it, but it's hard for me to justify the additional side effects of chemotherapy and just the additional burden of receiving treatment for patients in that category. So maybe we could just sort this out by PD-L1 levels. In the group of patients with, and this is for both histologies, with high PD-L1, would you think monotherapy, or are you in favor of the combination?
Yeah, I think it may be a good idea to look at Keynote 42 a little bit more. So it was presented, and it is a trial that looked at all patients with PD-L1 positive tumors, 1% or higher, and clearly was overall positive. But when you analyzed a little bit more, and they did that to their credit, the patients that had a PD-L1 level of 1 to 49 really had very marginal benefit compared to chemotherapy. And I think that is really where the algorithm that I think you're trying to propose comes from, that all of us, I think, are very comfortable to offer monotherapy to both squamous and non-squamous for PD-L1 over 50 patients, and then would probably consider and simply spare patients the toxicity, just as you mentioned, of chemo. And then for those that have lower levels, consider the addition of chemo with pembrolizumab or arguably atezolizumab, and expose them to the triplet.
Yeah, I agree with that completely.
And so then the question comes, where do you then, in your practice, because you have a lot of experience with this, in addition, use TMB?
Right. So I think it would be for the category of patients who are PD-L1 negative. Because if you just look at the trials which didn't include TMB, and you look at the data, then you'd say, what should I do in that group of patients? Should I give them pembrolizumab plus chemotherapy? Based on all these EMPOWER trials, should I give them atezolizumab plus chemotherapy? We heard additional data presented today in the non-squamous subset that suggested that there was benefit across PD-L1 levels, including 0. But when they showed the curves for how patients did with very high levels or 1 to 49% or absent, there was a shrinking benefit. Yeah. So that's where I think I would, if I had it, I would employ the TMB data to help guide me. Yeah. Now, I guess the other thing is, you know, the nivolumab, ipilimumab combination is not FDA approved yet. I'm not sure whether it will be. Yeah. But it is being reimbursed in the United States. I know our audience, some of our audience may be international. And the reason I mention that is we're at an ESMO meeting, and the ESMO guidelines last week added nivolumab plus ipilimumab combination as a recommended combination based on TMB. They even included that. So that was pretty forward thinking. What do you think there?
So I think this is important to sort out. So this is a subset of patients that are PDL negative but TMB high. And for that subset, you don't consider the addition of chemotherapy necessarily, but the addition of ipilimumab. And I think that the Hellman data, really from 227, do support that. I have very limited personal experience with that, but you know, some experience with it, and I do find it actually tolerable, somewhat less predictable in terms of toxicity development and particularly late toxicity development. But I think you're right. It is that group of patients to consider that in.